we've learned to say sex does not do harm, and we understand why sex can stir it up.
Another question around this and practical side of things. Is it okay to have sex while you have a chronic bladder
Right
infection?
now, sex, the thing, if you want to, I used to, when I was working on my own, I used to tend to avoid to ask about sex simply because I hadn't, the pressure on the clinic was such that I couldn't get through the work.
Mm-hmm.
And then a girl who I started treating when she was medical school, the medical student, and then subsequently qualified, who's worked with me on research and so on. She gave me an absolute bollocking for not asking about sex or beating up, and she was pretty impressive. So I then started asking about sex, and I really regret not having addressed this before. And in fact, that asking about sex has now become an astonishingly important part of our outcome measures.
Yep.
And when I'm treating patients, part of their homework is having sex. Now, why should that be? Well, first of all, we discovered that having sex can be painful, and there can be a painful aftermath, but it doesn't do harm.
Okay.
And if we've got people having sex, we're able to have them reporting, well, it got better, and then it got better, and then it got better. And we use that as an outcome measure.
Yeah, that's
now, the
good.
thing is, the other point is that if you're sexually aroused, you may not sense pain. So some people have sex and they don't get pain, and then shit hits the fan afterwards, and it's horrible. But learning from that, we've learned to say sex does not do harm.
Okay.
It's all right. And we understand why sex can stir it up. And the reason being is that during sex, you can perturb the cells of the bladder because of the pressures in the pelvis and all that kind of thing. And if you perturb the cells, the bugs that are colonizing those cells will get a fright. They'll wake up, start dividing. I mean, if you give a bug a fright, it'll just start dividing. That's all they do. That's their one reaction to adversity: divide. And as a result, they produce a whole lot of progeny that then burst out and charge for safety. It's like a murmuration of starlings, really, a similar principle. So the way we address that would be ready for it. You up your dose if you have sex, and then you will increase the concentration in your urine, and that'll deal with the acute flare.
Should you up the dose before sex if you can?
Yeah, it's quite a good idea if you can plan ahead,
which is not often the case.
No, I mean, actually, I'll tell you something. People bloody don't. One of the things I suffer from terribly is that a couple come in and I see her and I treat her, and a few weeks later she writes and says, "Dear Prof, I'm pregnant." She got pregnant without my permission. Damn it! But the thing is that people are so used to not becoming pregnant because they got a chronic urine infection that you treat the urine infection and then become fertile, and they become pregnant before you got a chance to really get the whole thing under control.
That's an interesting point that you just made, though, the connection between infertility and chronic UTI. Is there something more that you can tell us about that?
Yes, that we know that urinary tract infection, I'll tell you, it's very interesting. Sorry, I keep saying it's very interesting. I hope it's
not. Just have to make sure it's interesting.
We know that that's the point. Well, it's very interesting to me. Okay, the urine infection is known to be a significant risk factor for miscarriage, premature birth, pyelonephritis, preeclampsia.
Right.
We also suspect that as part of the miscarriage thing, it may be a factor in infertility. And certainly, I'll tell you something, evolution tells us something about that, because the normal woman, when she becomes pregnant, starts shedding epithelial cells like there's no tomorrow. Now, it doesn't make sense to start shedding cells when you're pregnant because you've already got nutritional demands.
Mhm.
So it strikes me that the human beings have evolved to try and protect against infection during pregnancy in a big way. So
Mhm.
we think that it plays an important role. The other thing is that I supervise all the pregnancies in our unit, and I've looked after 277 of them. And the obstetricians tell us that our rate of miscarriage is too low for women who've got chronic urine infection. So in
Mhm.
other words, we might be doing something right, and they're looking into that.
Yeah.
And the other thing is that I've had infertility doctors referring women to me because they thought that they had urine infection, and it's not uncommon. I mean, it's informal this, but I've got this problem of people becoming pregnant when I hadn't really wanted them because we hadn't quite got it under control.
I assume they continue their treatment throughout their pregnancy.
Yeah, that's right. And we were able to use the sort of Kefalex and nitropentone incredibly safe in pregnancy.
Mhm.
We're very conscious of safety with pregnancy, so that I got a rather obsessive approach to monitoring and looking after them.
Would you ever take someone off their antibiotics if they reach the point where you would normally take someone off antibiotics if they're
Not
pregnant
during
at the time?
pregnancy.
Okay.
Not during pregnancy. If they got, I'm absolutely scared rigid of a blow up during
Mhm.
pregnancy because prematurity is not a funny thing at all.
Yeah. Speaking of coming off the antibiotics, how many patients can come off at that point and then never have to go back on? Or do you think most people then have to try again and it takes a few times?
I don't know the answer to that one. And the reason being is that once we've got them off onto hip prex, I give
Mhm.
them a kiss and some instructions and wave bye-bye,
Right.
with the option that they can contact me, if there are any problems. And
Mhm.
so I don't know what it is. What we do say is that as they will leave our care while still taking hip prex with instructions on when they feel safe, to
Mhm.
decide on when they're coming off. We give them, what we do say is a lifelong habit. You must have some antibiotics with you, and you
Mhm.
must self-medicate at the faintest hint of any trouble, whatever you do. And
Mhm.
I talk about some woman who came back to me and once years ago and described how she was in the lunch queue at work, and she thought, I think I might be starting a urine infection, so she took the antibiotics with her lunch. She had them with her. That's what we advise people to do.
Mhm.
And we found that if you do that, you find yourself in that 3-day group. You can take it for a very short period of time
Mhm.
and abort it. So we're really keen on immediate self-medication on the faintest hint of any trouble.
Is the idea that you would take the antibiotics until your symptoms have
Yes,
disappeared?
that's right. So we say start it, and there's on our regimes, there tends to be 12 hours between doses. So start it.
Mhm.
You've then got 12 hours to decide whether you're getting better, have another
Mhm.
dose, and usually it's 1 or 2 days. We
Okay.
got some people who take it for a week because they're buggered if they're ever going to risk going back to
I
that
can
and so
understand
on.
that.
And I understand. I don't think that does any harm at all.
Okay. So maybe we can talk a little bit now about other side effects of antibiotics.
Yeah.
Obviously, a lot of people suffer from yeast infections or BV and have trouble taking long-term antibiotics because that can cause a lot of issues. What's your approach there?
Well, I have to say that in those days, going right back in the sort of the beginning of this century, that it was becoming clear to me that I was just not going to manage these patients without protracted antibiotics that were
Hmm.
lasting much longer than I'd ever envisaged.
Hmm.
And I was an terribly worried man. And I remember sleepless nights out in the garden there, just worrying about this. And so we adopted an obsessive approach to toxicity, side effects, and the such like. And our data scrutinized it meticulously. So that in fact, when we had our crisis in 2015, we were being looked at by everyone, we were able to produce the most remarkable data sets on side effects and consequences no one was expecting. And so it continues. So that we've looked at side effects very, very carefully. Secondly, that I've now treated well over 7,000 patients. I'm not sure how it is, but 7,000 have gone through the stocks. Now, so what are we worried about? Well, they're the idiosyncratic responses, side effects. So you've got people who are allergic. And very often people come and say, I'm allergic to penicillin. Most of those will ask them to do a skin test because people are often not allergic to penicillin. And it's better to get skin tested to know, because if they say they're allergic to penicillin, it can rather reduce our options, which can be a bit worrying. Resistance, this is the key point. We measure resistance and we keep measuring it all the time. If we extract microbes from someone's urine when they first arrive, and then when we see them after they've been on their treatment for their first review visit, and extract microbes and measure the resistance, it will rise very slightly, the resistant measure that we use. After that, it doesn't alter at all. Okay, so the resistance profile of the bugs in your urine shifts slightly in response to the antibiotic that you're prescribed, and after that, nothing tends to happen. So that the evidence is that we're not creating resistance by using these long-term regimes. Now, the anatomy of that has to be scrutinized in a great deal of way, but I wasn't terribly surprised to see that, because Darwin told me that probably would be the case.
Right.
It fits mathematically with Darwinian evolution for a whole lot of complex reasons I don't want to go into, provided we don't start shuffling the antibiotics, that we strictly limit our prescribing to the first generation where we start off and stick at it through thick and thin.
Right.
Now, the next thing is the bowels. Yeah, antibiotics can alter the bowels, but what I've learned over time, I thought about this a lot by intriguing, watching we feed birds out in our garden, and it's very noticed to see the way different species of birds feed in different ways. And sometimes you want to go out and say, listen, you dickhead, the food's there. Why are you feeding there? And also that they will go for different, for instance, I've noticed recently that the starlings will go for little worms, whereas none of the others want that, and so on and so forth. That's very interesting. And it was in discussions with the gastroenterologists that I thought that this might make some sense. Resistant starch are foods like potatoes that have been cooked and cooled down, so potato salad, pasta, cooled down pasta salad, and various pulses of one kind and another. Now, they're called resistant starch because the starch in them is incompletely digested in the small intestine, so it goes through into the large bowel, and there it provides food for the sort of bugs that you want. All right, so if you feed them, they will come. If you build it, they will come. That comes from that film, but if you feed it, they will come. So we've gone a big deal on using resistant starch, and it's had I mean, once again, this is just survey data, observational data, but we can pick up that the bowel problems have reduced substantially.
Okay.
And we don't encourage people to start mucking around with probiotics. And if they want to have probiotics, then have kefir. Partly because that acts in a similar way.
Last time you and I spoke, you said that you had never tried kefir. Is that still the case?
No, yeah, it was a good point. Well, I went off and tried it. God, I rather like it. I like yogurt. It's just like yogurt. It's really nice.
Yeah, I think so
I
too.
thought it was going to be absolutely ghastly. It
No,
wasn't.
it's delicious.
Yeah, it's very nice indeed. So that's okay. That's all right. Now, as to the vagina, there again, we got into awful troubles, really, by treating Candida with fungicides. Now, the problem with this is that if you treat someone with a fungicide, it clears up and they feel much better. You stop the fungicide and back it comes again.
Yeah.
So we've gone back to ecology, Darwin, and the such like, and we've majored now in a big way on acidification of the vagina. So we encourage people to use boric acid or some other convenient acidification thing. There are growing numbers of them, but to do it all the time, not in the, and if people who are acidifying their vagina, you're creating an ecological circumstance where the Candida can't thrive, and neither can the BV and all the others.
Does all the time mean using a suppository every night?
No, the boric acid is twice a week.
Okay.
All right. And a lot of these things are like that. You don't have to do it all the time. I'm very apprehensive about oral antifungal agents and these pesticides and so on. The fungicides, I just don't think that they're working. And it comes back to this, the whole principles of rewilding and ecology and so on. Let's do it using our understanding of the selection of the bugs, all right? And of course, the diagnosis of BV is based on measuring an alkaline, a relatively alkaline vagina. So, you know, the acidification of the vagina, the BV is not going to thrive. So that's the way we do with that. Now, the other thing is that there's an awful lot out there about the way the microbiome of the bowel changes when you're exposed to antibiotics. And children are given antibiotics, they've got a different microbiome and so on. And then people build this up into doom, the end of the world. Okay. I honestly, I'm really not terribly convinced about that. The reason being is that in the bladder, we know that there are well over 450 different species, loads more than that. So it's a kind of mulligatawny soup of microbes of one kind and another. And if you perturb it, throw it up in the air, bring it down again, it will reorganize itself in a different form. So it's no surprise that if you perturb it by putting someone on an antibiotic, throw it up in the air, bring it down again, when you measure it later, it'll be in a different form. But I thought there was a brilliant video I saw the other day that was suggested to me by someone on Twitter, which tells the effect of reintroducing wolves into Yellowstone Park.
Oh, I've read that article. Haven't watched the video.
The video is brilliant. Brilliant. And it once again brings back to this point that if you just let it be, the evolution and ecology will come together and recreate how things were. So I simply find it very hard to believe that you're getting sort of long-term catastrophic effects on the bowel. And the other thing that everyone forgets is the bowel is full of microbes. And we call antibiotics antibiotics because they're produced by microbes. They're invented by microbes. And what they do is microbes produce antibiotics to kill off other bacteria so that they can have more to eat. So if I'm a bacterium producing an antibiotic to kill off my competitors, I must also produce a resistant factor or I'll kill myself. So bacteria are constantly co-evolving antibiotics and resistance all the time. And they've been around for 3.5 billion years, squabbling these microbes. So it is, you would expect antibiotics and resistance factors to evolve long before humans even were thought about. So if you go into the Lecuguilla caves. The Lecuguilla cave, or cave, my editor says it's cave. I thought it was caves, but anyway, cave, I'll do as I'm told. A section of the Lecuguilla caves in New Mexico were sealed off from the rest of the world for 4 million years. That's a phenomenal, 4 million years. Now, we humans evolved 120,000 years ago, so 4 million years. And so that the biologists had this option of, they found this seal bubble, not been touched for 4 million years. So they put probes in and sucked out the contents and studied the microbiology. Now, would you believe it? They grew from those caves bugs that were resistant to 14 or 18 different antibiotics, including, would you believe it, mycaphalexin, which is a synthetic antibiotic invented by human beings. In fact, if anyone's sort of got any anxieties about cephalosporins, I can tell you that they were developed from Sardinian sewage effluent.
Nice.
So you can think of that when you're eating Sardinian shit to get better. But so the point being is that the if you've got an environment where there are bacteria, there will be antibiotics. And remember that we consist of 20 trillion cells and 20 trillion bacteria.
Mm-hmm.
And those bacteria are living with us in a mutualist relationship. And I assure you that they're squabbling with each other and producing antibiotics and producing resistance. So it's a much more subtle problem. And I think a lot of the AMR problem comes from people treating on culture. So you culture something, you're convinced that that's the cause of the drug, the thing. So you treat people based on the resistance of that. When you culture again, it's inevitable, Darwin, that the bugs you grow will have a degree of resistance to the antibiotic you use. So you use a stronger one and a stronger one and a stronger one. And I think we need need better methods of studying causation to get around that.
Yeah, it does sound like it.